Okay, so today we're going to be talking about psoriasis. This corresponds to chapter 3, section 1 of Olicon, the first part of it, where they talk all about psoriasis. There's a lot of very high yield factoids. Anything that was bolded in Olicon is typically considered high yield, so I have those things highlighted here. And then some of the information is from some other sources, such as Boards University, Boards Prep Plus, Derm Bank. And some of the photos are from other sources like Visual DX as well. Okay, so what gene is most important in psoriasis pathogenesis? And I'll pause. Feel free to pause if you need more time to think about it, and then we'll go through the answer. So this is source one, and this contains the HLA CW6 allele, which has the strongest association with psoriasis. What other HLA alleles can be associated with psoriasis? So we just said CW6 is the most common. A lot of us remember from med school that B27 is related to psoriatic arthritis and the ankylosing spondylitis family. So that's one of them too. And then also HLA B13 and 17 is associated with gut tape and erythrodermic psoriasis. And then B8, BW35, CW7, and DR are associated with palmoplantar pustulosis. What cytokines are increased in psoriasis? And sometimes if you think about the treatments that we have for psoriasis, this can kind of help you. Like, we use TNF alpha inhibitors and IL-17 inhibitors and IL-23 inhibitors. So this is Th1 cytokines. Um, so this includes interferon gamma, IL-2, 12, 1, 6, TNF alpha. IL-23, which then increases the Th17 inflammation, which is IL-17 and IL-22. CXCL8, which is important for neutrophil chemotaxis. If you think about the path, which we'll talk about, there's neutrophils always in the sternum corneum. And then some of the antimicrobial proteins as well. And that's important because eczema tends to get super infected with like staph or other things versus psoriasis tends to not. And it's because there's these antimicrobial proteins that are expressed. Great. Okay. What cytokines are decreased in psoriasis? IL-10, which is like an anti-inflammatory type cytokine. What are triggers in psoriasis? So things that can bring psoriasis on. So trauma, it does have the Kebner phenomenon. Infections like strep pharyngitis, that's especially with gut tape. HIV, certain endocrine factors like hypocalcemia and pregnancy, stress, certain medications. So the TNF alpha inhibitors are important because they can be used to treat psoriasis, but they can also induce psoriasis, and I've seen this before. Steroid tapers. So a lot of times you'll be on steroids for something else like asthma. And then when you stop it, you get this rebound of psoriasis or like onset of psoriasis. And then alcohol, smoking, and obesity. One that's not listed here, but does come up sometimes is that the PD-1 inhibitors can cause psoriasis as well. Okay, what's the best diagnosis of this? So the way that I would describe this is pink papules and plaques with thick micaceous scale. And then another thing you could say is that they're very well defined. So this is more of like the papulosquamous category. So this would be chronic plaque psoriasis, most commonly at the scalp, knees, presacrum, hands, feet, and genitalia. Okay, what likely occurred prior to this eruption? So this one kind of looks like smaller ones, kind of like the classic thing is like if you took a paintbrush and like flicked it, it's like little raindrops. So this is gut tape psoriasis. And that usually occurs 1 to 3 weeks after group A strep infection, either of the oropharynx or the perianal area, like perianal strep. Um, it can also be caused by a URI as well, like a viral upper respiratory infection. Okay, what is the best diagnosis for this one? So this one you have erythema pretty diffusely, and then it's studded with these pustules. So this is the von Zumbusch type of generalized pustular psoriasis. It presents with generalized, it presents like more generalized, and it's painful skin, fevers, leukocytosis, albuminemia, malaise, and it's associated with hypocalcemia. What is the best diagnosis for this one? So similar, but it's on the palm, but it's still studded with those pustules. So this is palmoplantar pustulosis, um, and this may be associated with Sappho syndrome. Okay, what about this one? A little bit more extreme, kind of going more onto the dorsal hand, not just the palm. So this is acrodermatitis continua of Halipo, and you see lakes of pus. So what that means is like basically they're coalescing to form like giant, it's not just a pustule anymore. It's like a big lake of pus. And so this can be on the distal fingers, toes, nail beds, and it can lead to nail shedding as well. What is the most common cause of pityriasis? I'm going to say this wrong. Menisciatiaceae. That's like when you get that really thick scale on the scalp. So psoriasis is the most common, but it can coexist with sebderm and like SIBO psoriasis. And then atopic derm can also cause that. What is the best diagnosis for this one? So this is the inframammary area. This is inverse psoriasis. So you get shiny pink, red, well-defined, that's the key, thin plaques with fissuring in intertriginous areas. So it can be behind the ear, the intergluteal cleft, the axilla, kind of anywhere that is intertriginous. Is nail psoriasis more common on fingernails or toenails? So this is fingernails, which if you've been in dermatology clinic, you know when patients have psoriasis, we always check their fingernails, but we don't necessarily check their toenails. Okay, so now we're gonna match nail findings in psoriasis to where the inflammation is. So for nail pits, where is the inflammation? It's in the proximal matrix. Salmon patches. The inflammation is in the nail bed. Leukonychia, the inflammation is in the distal matrix. And that one probably makes the most sense to me because if you remember, the proximal matrix is making like the underside of the nail, and the distal matrix is, wait, never mind. Forget about what I just said. I was gonna say it wrong. So it's the proximal matrix is making the top part of the nail, and the distal matrix is making the bottom part of the nail. So it's like the rainbow thing. Um, so I guess that makes sense for the pits because that's more on the top part of the nail. Okay. Onycholysis is with the nail bed, and then oil spots are with the nail bed as well, which oil spots and salmon patches like tend to go together. And then splinter hemorrhages are the nail bed as well. So most of them are nail bed. Pits are proximal matrix. Leukonychia is the distal matrix. So like more on the undersurface. How does psoriatic arthritis typically present? Like what joints are involved? What other features do you see? So this occurs in about 30% of psoriasis patients, and they have a negative rheumatoid factor. Their first symptom is usually morning stiffness that lasts greater than an hour. And nail changes can be associated with this as well. And then they have this enthesitis, which is like pain at the tendon insertion point. And there's a strong genetic predisposition with HLA-B27. So what are the 5 different patterns of psoriatic arthritis? So this kind of gets more into like which joints are involved. So there's the oligoarthritis, which is just like certain joints are involved. So that's usually the DIP and PIP joints in the fingers, but it spares the MCP joint. Pattern number 2 is when you have asymmetric DIP involvement, and that's when you get like that sausage digit. 3 is RA-like, so it's small and medium joints. 4 is the ankylosing spondylitis. So that's like the lower back. And then five is arthritis mutilans, which is the telescoping phenomenon when the fingers kind of look like they're going into each other. Okay, what are comorbidities of psoriasis? So common things that are associated with that. I think the one we think about the most is cardiovascular disease. Um, and that kind of runs with like hyperlipidemia, diabetes, metabolic syndrome. They're also at increased risk for lymphoma, onychomycosis, and candida, especially in inverse psoriasis, and then also uveitis, but they're at decreased risk for allergic diseases and superinfection because, again, they have those antimicrobial peptides. What are the classic histopathologic findings in plaque psoriasis? So you see parakeratosis, regular acanthosis, which is thickening of the epidermis, but it's regular in that it's regularly spaced versus sometimes we see it like kind of all over the place. Um, and then you have elongation of the reedy ridges with thinning of the suprapapillary plate. So that's like thinning of the epidermis right above um the papillary, like the, let me draw it out again. So if you have this, you have thinning of the epidermis right here. And then you have decreased blood vessels here, or dilated capillaries here. Sorry, that's what I meant to say. And then you have micropustules, so those neutrophils in the stratum spinulosum and in the stratum corneum. What are the histopath findings in gut tape? So this one is like a little bit more mild, but you have mounded parakeratosis. And then you also can see some mixed perivascular infiltrate with scattered neutrophils, and a decreased granular cell layer. What are different treatment options for psoriasis? So there's a lot, but you can do topical corticosteroids, topical calcineurin inhibitors, roflumilast, which is Zoryve, which is like kind of a newer option, and tapinarof, which is Vtama. There's also phototherapy. Usually it's narrowband UVB, but broadband UVB is more effective for gut tape flares. Um, and then there's a lot of different systemic options. So there's apremilast or Otezla, methotrexate, acitretin, and then biologics. So that's like your TNF alpha inhibitors, IL-17 inhibitors, IL-23 inhibitors, etc. What is the Warnoff ring? So this is when you get blanching around psoriatic lesions. Just a good buzzword thing to know. And what is the Auspitz sign? So this relates to how you have those dilated blood vessels and the thinning of the suprapapillary epidermis. So if you pick off the scale, you see pinpoint bleeding, and that has to do with like you picked it right at this spot, and there's a dilated blood vessel right there. Another good buzzword to know. Okay, and then this is just highlighting treatment choices for different types of psoriasis. One thing that's important to know is that spesolimab, or an IL-36 inhibitor, is now available for pustular psoriasis flares. So that's something new going on. And then pustular psoriasis of pregnancy. Um, this can be treated with prednisone. That's kind of like the exception. Usually you want to avoid prednisone in psoriasis because it can cause rebound when you stop it. But in pregnancy, it's more of like an emergency, so prednisone is appropriate in that situation. So that is it for now, and we'll come back with another topic soon.